little bit about it earlier on how you choose what design of your implant versus another. But can we kind of go into implant designs, like when you'd use a cemented versus a cementless versus a porous, or uh, press fit implant? Can we kind of talk a little bit about these different types of implants for hip arthroplasty?
Absolutely. I think the traditional gold standard is still probably a cemented femoral component and a cementless acetabular component. Um, in the U.S., we tend to use mostly cementless. That's what I use for most of my patients. It's a little bit easier if you have to do a revision. Obviously, as a lot of people would argue that you shouldn't do something based on the revision. You should do something based on how to make it work best primarily. Um, Patients that are older, patients that have had like a femoral neck fracture, I always use cemented for a femoral neck fracture because, as one of my trauma staff told me, they just broke the biggest bone in their body with a relatively innocuous fall. So they're trying to tell you that their bone cannot be trusted. So put
Mm.
cement in there. Um, I think there's a lot of the good data on the cementless components that a lot of them are just as good as a cementless component at this point in time. There's definitely a higher risk of fracture during surgery and after surgery with a cementless component. With the cemented component, there's a little bit higher risk of pulmonary insult, and then obviously revision can be a little bit more complicated unless you're doing like a cement and cement or one of the more, one of those techniques. It's a little bit on the advanced end.
And how do you choose which like porous coated, if you're doing cementless femoral stem? How do you choose which stem? Because sometimes we'll go to like these meetings, like 13 stems in front of me, and I'm like, I'm not sure how to choose from any one of these. How do you like go about choosing those? What to
Yeah.
use?
So I think as far as this applies for hip and knee replacements, if you're using one of the big companies, the Stryker, DePuy, uh, Smith Nephew, um, using one of the big components as well as Zimmer Biomet, all of them have good implants, good track records. I think a big decision, which isn't going to fall into the OID questions, but a big part of your decision is the reliability of reps. Wherever you're at, different parts of the country, different companies have better reps, and that's a big determinant. You could have the best implant in the entire world, but if your rep is not reliable and doesn't get you all the stuff or have all the equipment when you need it, it doesn't matter how good they are. Um, and then as far as the stems, usually most people have a couple of stems that they're comfortable with. They use fairly often. I use mostly stems that I used in fellowship. For posterior, I use Accolade, and then I use the Trident 2 Cup. And then for anteriors, I use usually DePuy Actus or DePuy Karai stem. Again, those are stems I'm more comfortable with. I like the Actus for the anterior because it's a dual taper. I like the concept of a dual taper stem from an anterior approach just because it sits in the femur a little bit better um, than the single taper like the Accolade does.
Awesome. Yeah. And like you say, uh, your rep can, in a way, they can kind of break, I don't know, I don't know if they can make a case, but they can definitely break a case. If you, like you say, you thought you had certain parts there and find out, you thought it was in the back room, but it's not even in the building or something. Yeah, it could really, really cause some issues. I have seen that happen before. Um,
Yeah, that's absolutely right. I mean, your rep will not make your case. I mean, if you need a rep to get through a case or to walk you through it, everybody else makes the joke about the ortho surgeon and their Stryker rep, being lifting buddies and drinking buddies, and everything else. But good reps are there. They make sure they have all the equipment there. I think the reps help the back table and your techs a lot more. I'm in a situation where our techs rotate every couple of months. So my most senior tech has been doing joints for less than 4 months. So it's good having somebody back there because at our institution, I'm training residents. I'm just over a year out of fellowship myself, so I'm still kind of getting things figured out what I like to do. And then there's techs that are learning as well, so it helps having somebody else to teach somebody, so I'm not kind of running all three parts of the game at once.
Yeah, that's actually kind of tough, but it's the reality at a large institution or learning institution, education teaching institution. You have moving parts all the time. People change, and so they have to learn your all your steps, and you have to kind of keep doing that as well as teaching residents. I'm sure that's something you like to do, but you just
Absolutely.
have to kind of keep going over your steps so that the case remains efficient and everyone is still able to learn as much as possible, but things are moving on like it should. um, and I like what we talked about as far as the implant designs, but before we move on, can you talk about like special liners that you may consider for certain patients? things like that, maybe like constrained liners, and when that would be something that you would use, and
Yeah,
things like that.
absolutely. So as far as the bearing surfaces, it's traditionally usually a hard-on soft bearing, which a hard-on soft means metal on poly, ceramic on poly, something of that nature. Some people will use a ceramic on ceramic bearing. Has very, very good wear properties. So for like younger patients, but there's definitely a side effect of a squeak that you can get, and a fair amount of patients have it if you actually ask for it, as well as the thing you worry about is a ceramic fracture. Usually the ball does not fracture, but the liner can fracture. And I've seen a couple of those. When that ceramic liner fractures, it's into a billion pieces. You can never get it all the way out. So you got to do ceramic on ceramic after that. And then as far as the kind of the advanced liners, where I can sort of think of as advanced liners, like a dual mobility liner. What a dual mobility is, it's a normal head with a polyethylene on it that is like a ball inside of a ball, so it can move around outside of it, and then inside it, that goes into a metal liner on the shell. So that allows a little bit more range of motion, a little bit farther mobility before you start impinging as far for risk of dislocation. That helps with reducing that. So I will use dual mobility in patients that have either like a prior spinal fusion, so they're going to be a higher risk for dislocation, or patients that I'm doing for a total hip for a fracture, as they can have a higher risk of dislocation. Constrained liners I try to use as infrequently as possible. What a constrained liner is the ball is actually locked into the acetabular side and then connects into the femur. So instead of allowing more range of motion before it impinges, it actually reduces your range of motion. But because it's constrained, there's a lot more stress going through the implants on the acetabular side. So you can get some more wear on the acetate or on the polyethylene, and you can also dislocate the polyethylene from the cup, which is an issue as well. So constrained is usually fairly limited use for me. Situations where I think of that is if somebody's got a very well positioned acetabular cup, very well positioned stem, and they just keep dislocating. If they've got like neuromuscular disorders, like we talked about earlier, Parkinson's, bad Alzheimer's, multiple sclerosis sometimes can have issues with that. Then I will think about converting it just to a constrained liner, but by and large, I try and avoid those as much as possible.
Excellent. And I think, we kind of spoke, I know there are a lot of complications that you can get from, undergoing a total hip arthroplasty, but I think we spoke about a little bit earlier. You're talking about the risk of iatrogenic fracture. Earlier, you were talking about what the anterior approach is. We spoke about instability. You can have recurrent dislocations. Of course, infection, which is a big risk and, a big thing with these periprosthetic infections or these cases. Are there any other complications that we should kind of generally be on the lookout for or think of, for anybody undergoing any type of hip arthroplasty?
Yeah, there's definitely other complications to worry about. Like you mentioned, infection, that's the biggest one. That's the thing that keeps joint surgeons up at night and paranoid as heck. And that's the reason that if you work with 7 different orthopedic surgeons that do joint replacements, you're going to have 7 different ways of draping, and everyone's the right one. It's all reducing that risk of infection. Other risks, there's damage-starting nerves. The lateral femorocutaneous nerve gets usually pushed a fair amount with the anterior approach like we talked about, but that usually recovers. You can have a sciatic nerve injury if somebody has a very short hip, meaning their hip is dysplastic, and if you're bringing their femoral head or their center of their hip back down, especially more than about 2.5 centimeters, you're going to have a higher risk of stretching that out. So that's something to watch out for. You can also injure the sciatic nerve directly. Shouldn't be much of an issue with a posterior approach, but you could definitely get close to it. Other issues, instability, kind of like you mentioned, that's a very, very big one that we worry about. It used to be someone they were at 10%. Now it's probably less than 2% for all comers, partially because we know a little bit better where to put our cup and our stem, and people are pretty aggressive about testing those. One of the things I like about the anterior approach is it's kind of like a video game. I get sort of a cheat code by using fluoro, so I can see exactly where my cup is. Once I've adjusted that fluoro to match the standing AP pelvis to make sure I'm getting their true inversion as well as inclination. Limb-length discrepancy is the most common reason, this is on the OID once in a while, of why orthopedic surgeons are sued after a hip replacement. I tell every patient beforehand, I'm going to try and make your legs as close as matching as possible, with the caveat being that if you are not as stable as I want you to be, one of my tricks is increasing the plus on the head size, which will make them a little bit longer legs, a little bit longer offset. And then polyethylene wear used to be a big issue back 20, 30 years ago. You know, my 707 or 719 joint replacements in fellowship and 120 some revisions, I did not see a single polyethylene wear, or I saw one revision of polyethylene for wear, and it was a poly that had been in since 1996. So
Oh
I think
man.
we've largely gotten
Wow.
that problem handled. You know, you guys talked about stems a little bit. The modular stems are at a little bit higher risk of having complications where the neck comes into the stem. They can get some metal on metal disease or some fretting there. So that's definitely a concern. And then the metal on metal, we don't really do metal on metal total hips. They still do it for resurfacing. That's a big still favorite of question on the OID as well as the ABOS examination is, you know, what to do about metal on metal, how to do the workup, the labs, and things of that nature. So it's definitely something to keep in mind.
Yep. And I think sometimes they bring up like I think you can sometimes get like a pseudo tumor and things like that. Is
Yeah,
that
absolutely. You
metal?
can get
Yeah.
a aseptic lymphocytic reaction. It becomes a big pseudotumor. When you get in there clinically, it's a big collection of fluid, usually just kind of either blackish fluid or the tissues around it look kind of abnormally black. And then when you look on the, usually on the trunnion, underneath the head ball, there's kind of a blackish color to that as well.
There we go. Dropping pearls. Well, Dr. Schuett,